Good morning. Seema encouraged me to take this talk, and I hope it is useful. Precision Medicine in Management of MAFLD. I have nothing to disclose except our residents are very good if they come on time. Metabolic dysfunction associated fatty liver disease. How do you suspect? This is for everyone. If somebody is diabetic, he has fatty liver. Overweight or obese has fatty liver. Or someone is lean and then has a waist which is plus blood pressure, triglycerides, A1C, or a family history. Then detect, manage, reverse fatty liver. These are new algorithms but based on same fundamental of MAFLD. So if there are two or more metabolic risk factors, here you can see the metabolic risk factors, or diabetes, or there is steatosis on any imaging, and there is excessive alcohol or CBC or liver function suggest, then you do a simple FIB4. If FIB4 is less than 1.3, this patient is low risk. If FIB4 is above 2.67, he is high risk and refer to a specialist. If it is the intermediate risk, in them, if it is 8 to 12, simple way of analyzing and categorizing fatty liver with high risk. There are new scores which at least the residents must know, Agile 4 and Agile 3+. These are to include, not exclude. So these are called rule-in scores, and which include LSM, liver stiffness, AST, ALT, platelet, diabetes, sex, and area under curve is 0.92. This is the conventional way we are diagnosing NAFLD. This is a recent paper from the Mohalla Clinic work which was done, which is accepted 2 days ago in APT. This is a cross-sectional study of 6,000 odd population. Now these patients had blood test and elastography also. This is the first such study from a general population from India, and it showed that 56% population from Delhi has fatty liver, and advanced hepatic fibrosis is 3 times more in those who have fatty liver versus no fatty liver. And also the risk factors included age, upper socioeconomic status, and low physical activity. So based on this study, an editorial came on the same issue that there is a tsunami of MAFLD in India. The reason for showing this is to say that we need to be aware of clear goals in this disease process. How are we currently managing MAFLD? So a patient comes and we say, oh, he is obese, he is lean, or he is normal weight. Then we say he is diabetic, whether there is a family history, there is adiposopathy, and then we diagnose. And then we put him into different categories. Then we also have started doing NASH gene profile, gut microbiota, bile acids, and others. These are all still in experimental stage. And then you have a tailor-made decision. Let's say he is obese. We'll say do diet, restrictions, exercise, lose weight of more than 10% or so, have coffee, low fructose. We can give metformin, pentoxifylline, saraglitazar, then lira or semaglutide or gliptins, SGLT2, put a balloon, change the bacteria. This is our current management of an obese MAFLD. If he has diabetes or NASH, then you give anti-diabetics, avoid insulin, lipid-lowering agent, saraglitazar. If the patient has complications, we treat. This is the way we have been doing, and I'll come to lean later. But there is no effective single drug for MAFLD. Why? There is a problem. This is a heterogeneous whole of body disease. It's not one organ. There are no markers for early or intermediate fibrosis. There is limited pharmacotherapy and lack of tools to diagnose therapeutic response and many cardiovascular and other comorbidities. So this is an important slide to tell you how we are doing conventionally today. As I said, demographics, behavior, diet, lifestyle, risk factors, screen, diagnose, and then finally treat. What are the precision medicine tools and how we can do it? And I'll come to them in a minute's time, but just to tell you, the precision medicine tools will depend upon the risk factors. What is precision and personalized medicine? Currently, as I said, our approaches are very blunted. 1 in 5 responds. In precision medicine, hopefully we can identify this man or woman, this age, what drugs should be given. We may go up to 40% or so success. And in future, personalized medicine for every single individual, 100% success. So these are the paths for us. You have big data, large electronic records, and you find out through all omics studies, and then you say, well, this drug, this cost, these drugs are effective, you give these drugs, otherwise you say throw them into the bin, identify which medicine to be given and to whom. So to start with, we must understand the natural history of MAFLD. Here risk factors are in blue and disease stages are in light yellow, and then the outcomes. So a patient has fatty liver, there is 1/4 chance that he will have hepatitis, and this is bidirectional. You can come back to steatosis. Then there can be progression to fibrosis, liver cirrhosis. Imagine once fibrosis occurs, it is unidirectional, but can be bidirectional, but by and large unidirectional. Development of cirrhosis and liver cancer can occur. The risk factors, now we'll see that these patients may have major adverse cardiac events 10 to 15% per year, and maybe malignancy 10 to 15% per decade. What are the risk factors in addition? Genetics and epigenetics. And this is a huge area, therefore now it is called genetics associated fatty liver disease, GAFLD. Now this paper by Manya, which has just gotten this last month or so, is an analysis of about 7 million adults from 36 studies. It shows you that the risk is many times more of cardiovascular, non-cardiovascular fatal disease in those who have got fatty liver. So in a way, people with fatty liver have a greater chance of developing CVD and deaths. So it is a forerunner for many other illnesses. Now let's start with some of the precision medicine tools. First is genetic risk factors. PNPLA3 I'll come to in details in a minute. The mutations can lead to risk of liver cancer about 5.9 times. TM6 again increases the risk. It causes decreased VLDL secretion. The glucose kinase receptor, it is the main molecule, the gene which regulates the glucose metabolism intracellular in the hepatocyte movement of glucose. This mutation again leads to increased risk, and the MBOT, which is for main polyunsaturated fatty acids, again increases, and HSD, which decreases the risk, is also related. So 4 of them increase and 1 decreases. What are these meanings of this? Let's first come to PNPLA3. This protein is in 2 main organs, liver and the retina. In the liver, it is in hepatocytes, it is in the stellate cells and the endothelial cells. What it does is to produce a lipid hydrolase. This lipid hydrolase causes hydrolysis of the triglycerols, make them into dye and others. So here are the lipid droplets which are forming. the lipid droplets will make secretion of VLDL, and this is the wild type of PNPLA3, where isoleucine is present. Similarly, PNPLA3 causes production from stellate cell of retinol, and this causes production of the inhibitors of metalloproteases, and the collagen formation does not occur. Now let's say there is a modification mutation. So the risk of NASH will increase 3 times, of HCC 12 times. What happens? Now instead of this, there is a mutant form of PNPLA3, so the secretion of VLDL is decreased here, lipolysis does not occur. So your liver cell is full of fat. Then the retinol secretion does not occur in enough, so there is deposition of collagen. So the variant of PNPLA3 which is present causes more risk for fibrosis, progression of fibrosis, and liver cancer. How common is this? In the US, this is the homozygous form. You can see there is a rise, and by 2030 maybe 4%, 5% of the US. Similarly, Japan, China, they will have an increased incidence of this, and they believe this will increase to 18 million by 2030. India, we do not have data, maybe some will come very soon. What happens if somebody has these mutations? So there is a high risk, there is a decreased lipolysis, and now we have commonly giving vitamin E to all these patients. If somebody is PNPLA3 mutant, that is isoleucine is changed to methionine, then your vitamin E or omega-3 fatty acids will not work. So there is decreased efficacy. In fact, that can lead to heart failure if the patient has cirrhosis and you have given this drug. What about weight loss and exercise? Fortunately, even if somebody has PNPLA3 mutation, there is a decrease in the weight and muscles, improvement in muscles with exercise. So no risk, PNPLA3 can be advised, similar lifestyle changes. Let's go further into susceptibility for FLD. Now these are called rocket diagrams. Rocket diagrams, the more the spikes, the more is the study, more is the strength of that study. And there are 4 genes which I told, PNPLA, TM6, HSD, and glucose kinase. Each one is given a score, MAFLD score 1, 2, and 3. So those with this mutation will have 3 times higher risk than others, TM62 and GCK1. And HSD, which is a protective gene, will protect you. Based on this, a polygenic risk score has been calculated. This polygenic risk score will identify the whole population, let's say 1.4 billion population of India. It will fall into a bell curve. So there will be a population who has a risk score which is low. They are low risk, don't worry. There will be a population which will be high risk. They immediately would require maybe a liver biopsy or assessment, and further management protocols have to be developed. But of course 95% will be probably into this category, and for them we can give them standard diet, physical activity. So our job is to identify these actually high risk population and bring them down. The polygenic risk score can be a beginning of how your population should be screened. There are furthermore advantages of doing genetic markers and epigenetics. So genes, one more with epigenetics is FGFR2, which is very strongly associated with fibrosis. MIR34A. Now some metabolites, especially bile acids. Now if you have primary bile acids higher in concentration, there is a possibility of more steatohepatitis. Gut microbiota, we know fully well that proteobacteria and enterobacteriaceae, they lead to more fibrosis. So I would suggest today we should find out an improvement to our what currently we are doing is do simple bile acids and find out E. coli status in the stool in a patient with MAFLD. So he comes, polygenic risk score and detection of bile acids and bacteria. What we do at ILBS, and thanks to Pramod who has helped us set up all this, everyone is doing 4 genes. Polygenic means 4. At ILBS we are able to do 60 gene scores, and I guess the cost is just about 8 or 10,000, which would be, I checked yesterday, close to $1,500. So the current data is about 550 patient samples were sent. Tests have been done in 387, and it includes all the important one, ApoB or it links PNPLA3. All these genes are present in the gene analysis. Now this is a very interesting data. Of 33 had no relevant mutation, but 354, almost like 85%, had mutations. The commonest mutations were PNPLA3, GCK, which is not a common mutation in the US. Now males versus females, there was almost equal proportion of both these. ApoB is also equally common, and PCSK, which is a gene related to LDL. This is very uncommon in the West, but in India you can imagine the PCSK is coming to about 17% of the population will have high LDL. The TM6, which is another mutation, is also present. This is different than what the West is doing. So we need a new polygenic risk score for our Indian population. Let's go interestingly further. Overweight or obese, lean versus non-lean. What is the status? So PNPLA3 is present equally well in overweight as well as in the underweight population. Here you can see this BMI may be 23 or so. Here the BMI may be 30 or so. And the mutations are almost same. Now FHBL is familial hypo-beta-lipoproteinemia. There are 2 genes. Please try to understand ApoB and PCSK. They have huge significance for us. So you have done serum lipids. Lipids are low. There is low cholesterol, low triglyceride, but you have a liver disease which is likely to progress. So this is familial hypo-beta-lipoproteinemia, and you can see how many Indians? A huge proportion of Indians have this population-wise. So let's go further onto the precision medicine tools. I have shown you briefly about the genetic analysis and the relevance of that. I have not shown you gut microbiome analysis, but I want to stress here that if you are doing bile acids, you will find out they are very important for us. The diacyl glycerols rather than triacyls are extremely important for us, C8, C10, and also the progression will depend upon availability of glutathione. So I have discussed with you broadly about obese and others. I will discuss now a very important emerging area of lean. How do we treat a lean NASH today? Well, 3 to 5% of weight loss, coffee and blah blah other things. This is a recent 2023 publication in Lancet which tells you the proportion of population with abdominal visceral obesity, more than 50% and 30 to 50% or so. And Delhi comes between 30 to 50% of visceral obesity. Let's go back to what the Mohalla Clinic data shows. We have 11.3% as lean MAFL, and they still have disease. This paper we had a few years ago, which says normal weight population metabolic dysfunction is present, and those countries with 30% or more have MAFLD. So Of the total population, 11% may have lean NASH. But if you take 100 patients with MAFLD, 30% may have this, and this is where India is. 30% may have MAFLD. So this is a new way of looking at lean NAFLD. So lean NAFLD may have two variants. One is monogenic, and one where other gene factors and environmental factors are there. So you do a serum lipid profile. Normally you will find out lipids are high, but this population will have low triglyceride, ApoB is low, LDL levels are low, and these are hypo-beta lipoproteinemic. They are FHBL, familial hypo-beta lipoproteinemic syndrome, and ApoB and PCSK9, these two genes will determine. And Indians may have 10 to 17% of this. What do you do in this? As of now, you just give them high dose vitamin E. Just do familial counseling. You may have another group where you have elevated TG, LDL, and these could be ABHD5. These mutations also are inherited. So Indians are inheriting these genes. The third can be low HDL levels, and these are one where you have lysosomal acid lipase deficiency. The pediatric population is well aware of this LAL, and you can give them specific drugs. So when a lean NAFLD comes, we must do at least these two additional genes, ApoB and PCSK9, which is available with us at ILBS. Let's go and understand little bit more about the lean NASH. Now in the lean NASH, this is not showing so well. The person is lean. Metabolically, there is much more fat in the center. In this lean but unhealthy person, the visceral fat is more than the subcutaneous fat. He is insulin resistant, muscle mass is low. On the other hand, there is a normal person who has less of visceral fat. Let's look at this. So these are two individuals, both have BMI of 22. The green shows subcutaneous, blue shows visceral, and red shows muscle. This healthy individual has good muscle and very less visceral fat. This other individual has lot of visceral fat, all that blue. So the visceral adipose tissue in this lean NASH is almost 5 times more than this other individual. So although BMI is same, he is unhealthy, and this is a healthy individual. And this is where Indians are. How do you find out? This is a data from an individual very recently done. He is a 30-year male, and you do their simple bioimpedance by body composition. His weight and should have been, the BMI should have been around this. But he has percentage body fat, although near normal BMI, his percentage body fat is 40. Much more than the 20% that is required. The muscles that he should have, anywhere you say arm, leg, everywhere the muscles are less. So if you look at it carefully, the amount of fat he has to lose is close to about 16, and the amount of muscle he has to add is about 7 kilograms of muscle. This is precision. This is totally personalized medicine. So an individual comes, any gender and age, you have individuals with gender and age. So every individual must have body composition analysis. The visceral fat unfortunately cannot be done so well, but you can make assumptions on this. So I strongly recommend, in precision medicine today, personalized medicine today, body composition analysis is a huge role. Let's move further. So we were at current medicine, the way we treat. How should we treat a NAFLD or MAFLD? We were doing trials which are umbrella trials. Here is a patient, his biomarker is, his cholesterol is this, triglyceride is this, insulin is this, and we were subtyping and giving treatment. Today and tomorrow we will have basket trials. So we will have a guy who has a liver metabolic dysfunction, he may have diabetes, he may have cardiovascular. This comes as a package in a human being. Now we have to treat this human being, and we therefore need drugs which can attack and handle all these three things and then personalize them using these trial data. Let's go into how the drugs for diabetes are effective. Metformin is more effective in South Indians, can you believe this, than people who are in US. The DPP-4, the gliptins that we use, the inhibitor which prevents the breaking down of the GLP-1, they are not effective as much in the Caucasians. The GLP-1 fortunately is more effective, and SGLT2. So these two new classes of drugs do not have any reduced efficacy based on genes. So we need to be careful for metformin, but no worries on these new drugs. Let's look at this new JAMA data just published end of last year, December. They compared the gliptins with the GLP-1 agonists. So GLP-1 receptor agonist was far superior than DPP-4 in NAFLD patients, and all-cause mortality was reduced significantly using GLP-1. So we need to move on from gliptins maybe to GLP-1 receptor agonists. Compare SGLT2 inhibitors, the GAPA and the flozins, then compare them with the gliptins. The SGLT2 inhibitor is associated with lower major adverse cardiac events. Here you can see, but equally well for NAFLD or non-NAFLD population. So now we have classified, we have to move from gliptins to the next generation and see whether we can prevent overall cardiac, overall effects on mortality in addition to the liver. Today, we still have a huge population because we do not understand MAFLD very well. So all of us have to work together. So in my summary, the precision medicine for MAFLD, the conventional tools, family history, the body composition, fibroscan, HOMA are conventional. We need to include characterize patient as obese or normal or lean. Then use precision tools. We have to start using polygenic risk scores, metabolomic and microbial tools. Choose your drugs carefully. Keep your LDL to 50 or less. The current Indian and including ILBS, LDL is 100. But if you have NAFLD and you have high risk of MACE, then the current 2024 guidelines for lipid societies is keep it less than 70, preferably less than 50. And statins, azetamide and newer drugs be added. And of course weight and exercise. Some work is going on at ILBS. Lean NASH was first. The largest study globally is by Archana. Familial clustering in NAFLD, Ankit has submitted. The data is being analyzed. NASH gene profile, thanks to Pramod, I showed you some data. Metabolic liver disease panels are available. Liver fibrosis panel have to start. And this I borrowed from Vaishali and Gayatri yesterday. They are doing this work, genetic variants, trying to develop a polygenic risk score. In addition, they are trying to give you the age of the liver by using telomere length. And a cell paper she shared with me, the age of the liver is always 3 years. It is the youngest organ and remains the young all throughout. And they are working on mitochondrial DNA copy number. This is the prelim results from Vaishali's work. It says that frequency of risk alleles is higher in alcoholic liver disease. So we are not talking of NAFLD. In ALD also the frequency is higher, and in India unfortunately the protective HSD is much lower. So I'll come back. Today we need to go back to the drawing board, improve our management, especially characterize your lean, type 1 or type 2, lean MAFLD, and give the drugs accordingly. Why reduce fatty liver at all? This is a data from a Korean study, 2009. They are at least 15 years ahead of us. So they had 3 million Koreans whom they followed, those people who had at the beginning no fatty liver in 2009, but they developed fatty liver. In them diabetes became twice, death was more. But more important is those who had fatty liver, but they reversed the fatty liver, death was decreased by 17%. So there is no question that you have to get rid of fatty liver. The efforts by India, and this is by Manya, which came in Lancet. If you control fatty liver, the NCD burden will decrease. So today everything is increasing, and in 1 decade we want to bring it down, and all these N's are for nurses. The healthcare providers have a major role to do the screening of the population, identify, risk stratify, and change the whole thing. Thank you for your kind attention.